My name is Karen Brazel, and I am very excited to be here with a really incredible group of women. Truly incredible to talk about improving diversity in acute care surgery. The way this is going to go is we are each going to introduce ourselves as our part in discussing this comes up. And we're going to introduce ourselves and how this topic came to be important to us, and then share some of our experiences. We're going to start with some data, and then, because I don't like just defining a problem, we're going to talk about some of the actual steps and suggestions to improve diversity and the equity inclusion that go along with that, and arguably are more important, or at least equally important to that. I will be monitoring the chat. So one of the things that we are that we want to make sure that we have time for is time to talk and chat at the end after the panelists have presented some information. So I am the immediate past chair of the AAST Diversity, Equity, and Inclusion Committee. That was not my first entree into this topic. I come at this as someone who joined the Association for Women Surgeons very early in my career. And I found that organization particularly helpful to me, and also I think as importantly, or more importantly, important to the trainees who would come to me looking for mentorship or advice. And when I did not have the answers, which was most of the time, I had a big network that I could rely on, because I did not have that network in my home institutions, and still to a degree do not have that network. That is a very, very small piece of diversity, but that was my initial entree into how I became interested and invested in this topic. And I have to say, more recently, it has been seeing some of the struggles that my residents and fellows have gone through that have kept me tied to the topic. I'm going to hand it off now to Dr. Shrewsbury.
Thank you, Dr. Brazel. I'm Shrewsbury. I am an trauma acute care surgeon at NYU, Crispin School of Medicine in Manhattan. I also am now the current chair of the Diversity, Equity, and Inclusion Committee for the AAST. And so I'm going to be sort of talking about the data and the pipeline, and where we stand in our mission, really to increase DEI within our field, within the House of Surgery. So Dr. Smith and Dr. Strong and Dr. Kyle introduced themselves. I'll go ahead and start with our slides. Dr. Smith.
Hi, everyone. My name is Randy Smith. I am an acute care surgeon here at Emory and Grady Hospital in Atlanta, Georgia. I also am on the DEI committee for AAST, as well as for the Society of Critical Care Medicine. And more recently was just appointed as the vice chair of Diversity, Equity, and Inclusion for my department at Emory. I'm excited to be on this call, and I look forward to the discussion.
I'll go ahead and go next. I'm Lillian Cow. I'm Division Chief for Acute Care Surgery at University of Texas at Houston. I am one of the founding members of the Society of Asian Academic Surgeons. I'm currently the chair of the work group for DEI for the Committee on Trauma. I'm on the AAST DEI committee, and I'm also the AWS rep to the American Surgical Association DNI committee. So happy to be here, and happy to hear what everyone has to say.
Hi, everyone. My name is Dr. Bethany Strong. I am an acute care surgeon at University of Maryland Capital Region. Just just finished fellowship about 8 months ago or so. So definitely easing into junior attending life. I am in the AAST DEI committee. I am the RAS liaison to the Committee on Diversity Issues, soon to be renamed, for the American College of Surgeons. And I am on the RAS Diversity, Equity, and Inclusion Committee. Diversity has always been important to me. My dad is like, oh, it's in your blood, but from civil rights in my past and from growing up. And so I was kind of naturally drawn to trauma for many reasons because of the disadvantaged patient population and the opportunity to do such good. So I'm excited to be here, and thank you all.
All right, I'm gonna start sharing our slides. Okay. All right, so again, I'm going to start with some of the data behind this, and this really started for me as chair of the Women in Surgery Committee for the Society of Black Academic Surgeons, where we really looked at some of the data, and it was really, you knew when looking around the room that you didn't see a lot of people that looked like you, but when you really look at the hardcore data, it was discouraging, but where there is a little bit of discouragement, it represents an opportunity to make things a little bit better. So I am thrilled and excited to be here. I want to thank Dr. Ken Davis, Dr. Eileen Bolger for the invitation and for the opportunity really to be a part of this important discussion today. No disclosures. So the 2020 US Census shows that the US population is really more racially and ethnically diverse than expected. And in fact, by 2050, we will be a country that is 47% Caucasian, with the percentage of Hispanics, Blacks, and Asians continuing to increase. And so why is this important? Well, diversity at the highest levels of leadership at academic health centers really contributes to critical and innovative viewpoints and organizational level changes that ensures excellent patient care, groundbreaking research, and really serves as a model for health professions education. And so when diversity is lacking, patient outcomes are affected. That's one of the reasons why in 2019, 2020, the college has really prioritized the issue of diversity and sort of creating a diversity pillar, which I'm proud to say I am the lead of that, and really excited about affecting change on a national level, because the fundamental questions really are twofold. Are we training a workforce that's not only reflective of the diverse patient population that we serve, but one that is really culturally competent and free from implicit biases? And is our surgical leadership culturally competent, free from implicit bias, and reflective of the diverse patient population to whom they serve? And so, according to our census, Caucasians represent about 60% of the population and about 55% of medical school graduates. Asian Americans represent 5.9% of the population and about 21.5% of medical school graduates. Hispanic Americans represent 18.5% of the population, but only about 5.3% of medical school graduates. And African Americans represent about 13% of the population, but only 6% of medical school graduates. And so the inequities among Blacks and Hispanic medical school graduates are really clearly present. And those disparities really continue and worsen throughout residency training at the faculty level and at the leadership level. As you can see, when we looked at this back in 2019 and publishing the 2017 data, at that time, there were only 10 African-American African-American women full professors of surgery. There are now 12, and that's out of 3,500 full professors of surgery. And it's only been in the year 2021, where a Black female ascended to the role of chair of surgery. In fact, not one, but three. That just happened last year. And obviously, the executive director of the college, being Dr. Patricia Turner, is sort of a first in the entire history of the college. So we are certainly making progress, but we have a ways to go. And so in turning our attention right back to trainees, there are many reasons why we're seeing the numbers of 3% and 6% at the trainee level. But I want to really highlight one of those regions, which is the attrition and retention of our underrepresented in medicine residents. This is the data from the ACT-ME, which looks at pipeline graduates dismissed by specialty. And the green bar represents Black residents. And Black residents, again, represent about 4 to 6% of general surgery residents, but you can see are disproportionately dismissed from their residency training programs, which is nearly 6 times that when compared to other races. And so it's really not surprising that we are seeing the effects in our specialty of trauma and acute care surgery. We just published this paper in JTACS this week, where we analyzed the surgical critical care applicants, matriculants, and graduates from 2005 to 2020. And of the nearly 2,500 graduates, 4.7% of the male graduates were Black men. And that's significantly declining by about 0.3% per year. And it's about 6.4% of the female graduates are Black women, but this is a significant decline of 0.6% per year. And in looking at Hispanic men, we're also seeing that decline. Hispanic men represent about 3.2% of our surgical critical care male graduates, but that decline of 0.3% per year was significant. We also saw a decline in the number of Black and Hispanic applicants in 2019 to 2020. And so the numbers are a little bit, or not a little bit, but are very discouraging, and we need to sort of figure out how to improve these numbers and ensure that our field is represented really represents the diversity of the patient population to whom we're taking care of. So I'm going to turn it over to my colleague, Dr. Strong, to really talk more about the resident fellow perspective and intersectionality. Dr. Strong.
Of course. Thank you, Dr. Berry. So can I advance? I might have to say next slide, like this is a formal presentation. Can you advance from? Thank you so much. So I wanted to talk a bit about trainees and intersectionality. Approximately 38% now of general surgery residents are female. However, general surgery in general continues to have a high program attrition rate, possibly only exacerbated by the recent pandemic. Attrition rate is approximately 18% nationwide. There is a higher attrition, as Dr. Berry mentioned, that has been shown among ethnic groups, specifically looking at Hispanic or Latinx populations. And then this leads you to question why. It's already, as is well known, a very difficult training process for some would say, both physically taxing, long hours, and emotionally dealing with patient complications and difficult patient situations. However, specifically Black, Asian, and those residents who identify as other feel as if they are less likely to fit in and into their residency programs. Additionally, Black and Asian residents were more likely to report that attendings would think worse of them if they asked for help, which is especially concerning in a training process when you're supposed to be growing, learning, and in a lot of ways asking for help. What keyed me in a bit more about this publication was that the Black residents felt they were less likely to even be able to go to their peers, their co-residents, their family that they're going through this process with, to ask for help as well. It was found that current diversity of programs does correlate with the diversity of the faculty that are at these institutions. And I know that was very much involved in my decision to attend residency where I did so few years ago, looking at both the female representation and leadership, and also the minority racial group representation. Next slide. Perfect. So now as I transition to what I like to call junior attending hood, there are some ways that I have noticed that have been helpful in really thinking through how to kind of level the playing ground and really interact in a way that can promote both female and minority advancement within fields. Something that oftentimes comes up is discussion of contracts and the differentials in men and women negotiating their contracts and being successful in that negotiation. So having early discussions with both male and female partners in regards to contract compensation has been shown to be successful. Additionally, highlighting the objective steps towards promotion. Sometimes the pipeline becomes leaky because subjective factors or assessment of the value of different tasks aren't even across roles that unfortunately tend to become more female. Additionally, maintaining mentor and sponsor relationships. I wouldn't be here if someone hadn't mentioned my name in a room full of people who realized the worth of this webinar and the work that we have all done in the past. And then also choosing an institution that aligns with your personal goals. As I transitioned from the role of fellow to the role of attending, I had to really sit down and ask myself, what makes me happy? I feel like throughout the training process, I was focused on making my attendings happy, having everyone's numbers ready, making my chiefs happy, and not really looking at the training setup for my institution and how it can continue to grow me as a surgeon. So for example, when I was a fellow at University of Maryland Shock Trauma Center, there was formal implicit bias training. And one of the most memorable sessions was when one of the representatives essentially asked us to turn on or off our camera screens based on different experiences that we've had. And really being able to connect with one another as a group and think about how this then translates to our patients and the best way to interact with them. Additionally, I can think of one story that was very interesting from an intersectionality standpoint. During the time of my training, I was speaking with one of our breast surgeons, and she was very upset. She was one of my white colleagues, and she's like, "I'm always the nurse. I'm always the nurse." I was like, "Well, I'm always food service." And so, having that chuckle in that moment, but realizing while we have similar struggles, there are differences and there are nuances that need to be highlighted and kind of exposed throughout this process so we can all succeed and advance. So the next slide is just my contact information. I look forward to any questions.
I think we can move to the next slide and I'll take over. So again, thank you for the opportunity to speak with you today about increasing diversity, equity, and inclusion in acute care surgery. And I'll be speaking more from the organizational and institutional viewpoints. And for my talk, I'll kind of be moving away from data and more into solutions. Next slide. So before I get started, I wanted to tell you a little bit more about me so that you understand the lens from which I'm speaking and why DEI is so important. And as you can see, I identify as a Black female. What some may know about me, most don't, is that I grew up in an urban underserved neighborhood in South LA that was riddled with crime and violence, drugs, limited resources, you keep going. But I came from a very loving and educated family, and I was able to go to the best schools, and eventually we moved to a lovely suburb. I'm also a mother of a toddler who is 2, almost 3 years of age, so pray for me. And after tragedy and missing a bunch of important life events, increasingly, I've understood the importance of being a devoted family member and friend. Next slide. So I always say, like, this is me, unapologetically. So next slide. So for me, DEI is more than a gender discussion or a race discussion or a socioeconomic one, because my life's journey touches on that as well. But it also involves making sure that, like, we celebrate and we honor what makes us unique and what I think needs to be seen. Next slide. Or sorry, actually go back to that. I want to say that, you know, when we have these discussions about diversifying the surgical workforce, just remember that you can't be what you can't see. And that's either physically what you can't see, like people ahead of you who've already achieved what it is that you're trying to achieve, or internally what you can't see, because people around you, you know, having given you the strength, encouragement, or confidence to blaze new trails. So next slide. So this is a very simplistic way of breaking up DEI. It's only one viewpoint, but you can think of it as, you know, what gets you in the door, what gets you to stay, and then what gets you up the ranks. And I do think that, like in my, what I'm going to talk about right now, I kind of touch on all aspects of DEI. Next slide. So this year I was selected as a future trauma leader with the American College of Surgeons Committee on Trauma. And do you ladies notice anything special about my cohort? Yes, we are all of us are just women. Some are mothers, some are military. We come from diverse backgrounds, but we're all qualified women. Next slide. And our wonderful RAS and YFA liaisons are also women. And so this is just a great example of just seeing the traditions change a little bit and there being more inclusivity in such a prestigious program like FTL. Next slide. For those of you who are not familiar with FTL, it is really a prestigious opportunity. And I'm sure that Sharice, who is a part of the 2021 cohort, can attest to some of the benefits of being selected and mentored by giants in the field. You know, you have these, it's meant for junior faculty, so you can't be more than 5 years out. It's in-depth training, you get one-on-one mentoring with giants, and you're working on some cutting edge projects that really have the potential to impact the masses. And they come in a variety of flavors. You can be involved with any of the pillars as you see there. There's advocacy, quality, education, injury prevention, and systems. And so whatever it is that excites you, there's probably a project for you or somebody that's willing to work with you to, you know, create a project for you. I'm just getting started now. My mentor is Dr. Rochelle Dicker, and we're going to be working a lot on injury prevention. But I also talked to Lillian about doing some DEI work. And so there's a lot of room for you to reach out, branch out, and do great work. Next slide. And I like this slide because, you know, mentors are really designed to support you, to help you develop and grow. And with programs like FTL and others, I mean, I find that to be a solution. I'm hoping that we increase diversity in our field, you know, for women and for historically marginalized or underrepresented communities so that people feel accepted and supported to thrive. Next slide. And then you can actually hit next for like the next two more. Yeah, that's perfect. So in the last minute, I'll just mention, I mentioned already that in January, I was appointed to be the Vice Chair of Diversity, Equity, and Inclusion for my Department of Surgery at Emory. And really, it was with the encouragement and support from several people that are on the call. I saw Niels Martin on here a little bit ago. I think that this is a big task. I think that is an important one, but it's certainly one that I'm passionate about. And I know that more and more of these positions are becoming available across the country. And as we accept more of them, I think it's, you know, very clear to outline what the role of the vice chair looks like for you. This is what I have envisioned for my role. And honestly, I just want DEI to kind of infiltrate throughout the entire department. And, you know, I'm going to create a strategic plan. I'm going to act as a liaison. I'm going to support DEI initiatives and oversee them. But really is to support the faculty so that everyone, when we get more people in the door, but then we get them to stay and then we allow them to grow and move up the ranks. Like going back to that early slide that I had. Next slide. And we have a bunch of subcommittees that do the work. Our priority is to really align with our department's missions and our School of Medicine mission. And you can see the different subcommittees there: education, research, community outreach, recruitment, climate and culture, which really gets at inclusivity, and then advancement. So again, really DEI infiltrating all aspects of the work that we do as a Department of Surgery. And keeping in mind that the E, the equity, also includes health equity. So making sure that we take care of our patients appropriately as well. Next slide. I think that's it. Okay, perfect. So I'm happy to network with all of you, and please do keep in touch. And I hope to have some great discussion in a few minutes. And I'm going to turn it over to Lillian. And I believe, Lillian, you're going to use your own slides. Yep.
Yes, I apologize. I did not get my act together to turn in the slides on time to use the WITS background, but I'm going to take it a little bit further from what Randy was discussing. But before I do that, I just wanted, she shared her story, and I will say that I am actually someone who in my early career used to think that DEI was not a problem for me, that I'd always had male mentors all along the way, that I, if anything, didn't want to be perceived as someone who complained about being a woman. I'm an Asian American, and Asians are seen as the model minority. And I really didn't see how that was actually a problem. I'd always, like many Asians, excelled at math and science. I played the piano and the violin. I was like on track to be the typical Asian American. But in fact, only more recently started to see where sometimes the model minority myth actually hurts us. So anyway, I just wanted to give you a little background. Obviously, I now see that more and more every day. I see how DEI affects us. Just a couple of days ago, our program director mentioned a fellow who was delivering Asian slurs to an Asian intern. I've hear more and more stories about how even though things are better now, women still have struggles. And so I'm now a convert in the sense that it does affect all of us, and we all need to join together to attack the issues. So anyway, I wanted to give you the perspective of the Committee on Trauma. And the Committee on Trauma position statement is that we're committed to upholding the principles of diversity, equity, and inclusion, both within the organization and the community that it serves. And I think, I really want to give a shout out to Eileen Bolger, who created this work group and recognize that there's a lot that needs to be done. In fact, we can't even address the community that we serve as trauma surgeons until we straighten out the COT. And so we started with just trying to say, who is the COT? I mean, we don't even know what the demographics are. In addition, we identified a number of issues. And so we described our core principles. We want to make sure we have a diverse representation in all aspects, including things like rural versus urban trauma, where your geography is from, in addition to, race, ethnicity, gender, sexual orientation, everything. We want to make sure that leadership is inclusive, that there's a transparent pathway to membership and leadership. Structural competency and having the right policies that govern our organization, having accountability, and making sure that bullying, harassment, and discrimination are not tolerated. Obviously, learning and education is an important component in sharing evidence-based knowledge. Based on a survey, we created 3 work groups that are really trying to tackle all these issues. And some other things that we've been doing is partnering with other organizations. So we've reached out to SBAS, SAS, LSS, AOSA, AWS, and I apologize if I missed any, but making sure that when there are opportunities that the right people get nominated, that we are doing things in concert rather than independently. Obviously with C. Armstead and Bonnie Mason, starting at the college, we have a lot more alignment with the rest of the organization in terms of our DEI efforts. And so, and maybe Charisse wants to comment on it, but we did get one of the ACS Regents grants, Board of Regents grants, where the AAST, COT, and Pediatric Trauma Society are working together to try to increase the pipeline. So I don't want to take up time from discussion, so I'm actually going to end there and stop sharing.
So as I said, I wanted to leave a fair bit of time for questions, as well as we have a lot of people on the call with experience and expertise. So whether you have questions or whether you will respond to questions in the chat, please feel free. This is truly a learning community, or at least I hope that's what it can be. I'm going to ask the panelists as we kind of get going and warm up the chat, to respond to this question, either from the positive side or from the negative side. What is the most helpful thing that you have either experienced or seen from an organization or institution in work to advance DEI? Or what is the thing that, although well-intentioned, has been the least helpful and supportive? And again, this can be either personal experience or something that that you have observed and know from the data standpoint. Lillian.
Okay, maybe I'll go first. So what I've seen that I thought was really illuminating was when the Association for Academic Surgery and Society of University Surgeons had a panel of both senior surgeons as well as one that included more junior ones who shared their stories and were very frank and authentic, almost uncomfortably so, about their stories. And it was just so illuminating because people were vulnerable and they really highlighted the struggles that they had. And, you know, I don't want to name societies, but I'm on a part of a group to plan a panel where there is so much angst over saying the right thing that everything is being scripted, and they're putting as many high-level people on the panel as possible to prevent any one person from being attributed as having said something. So to me, and I get it, it's a challenge, and I'm not, you know, and I'm happy that the organization is addressing it. But to me, we lose authenticity when we start scripting what we're going to say because we don't want to say the wrong thing. So that's what I'll say as far as societies.
I'm before the other panelists jump in, I'm going to say I firmly believe we will not get as far as we can if we do not invite those, and I can say this with my gray hair, if we do not invite those who are younger to be on the panel and share their expertise, whether it is expertise that comes from their own personal experience or the data that they are creating. They know more in many cases. And if we cannot get past that, it's, as Sharice's data showed, it's going to take us an incredibly long time to get to where we need to be.
I agree with what Dr. Brazel was saying and what Dr. Powell was saying. And I think, you know, this topic is, everyone is very passionate about it. Most people are very passionate about it. And it, you know, in sort of talking about it, it can be uncomfortable, but it's okay to be uncomfortable. Because we're never going to move or advance DEI if we don't talk about, you know, where we can improve and not be open to new suggestions and interventions to make things better. I'd say from an institutional perspective, our institution here at NYU actually created an Institute for Excellence in Health Equity and has begun piloting equity councils in various departments and being very intentional about health equity metrics, implementing that within every unit within our hospital. So we're going to begin looking at health equity metrics by race, ethnicity, gender, are just a couple of them. When we look at our quality metrics, when we look at our patient experience metrics, when we look at our hospital operational efficiency metrics, because as you know, the saying goes, you know, you can't improve something if you don't measure it. And so you got to look at it. You got to look at your data. And when you look at it, when you look at the hardcore data, you know, that people, you can't argue that. You can have emotions, but you can't argue with data. And if it's showing, for example, in 2019, 2020, when we published that paper where there were 0 African-American female chairs of surgery, that's a hard number to look at, and without saying, okay, we need to do something about that. And so I would just encourage everybody to really focus in on data to help drive change.
In conjunction with what Dr. Berry was just discussing, I would say what I've seen to be most helpful are when organizations try to truly identify the problems or issues in an intentional way in order to directly address them, whether it be in terms of promotion, whether it be in terms of patient care outcomes, what has been least successful from what I've seen that was popular probably a couple years ago were the blanket statements of condoning certain actions, condoning certain behaviors, and in support of minority groups, but without either a plan to address and for next steps or the financial support for those next steps. Because I also know of people who have been appointed as the chair or the dean of diversity, equity, and inclusion, but have been provided with a $0 budget. So it's hard to really move forward and address an issue and really to see it as being taken seriously when you're not provided with the tools to address it.
Yes, I was literally going to say the same thing, is that you need resources to do this work. You know, one of the things that I talked to the chair of my department about was not only having fiscal resources, but human resources, because it has to be from more than just myself. But you're absolutely right, Bethany, like it takes a lot, and the dedication from departments and from organizations, it really does show when people put dollars and cents behind the work that you're planning to do. I'll say that I've seen a lot of great things in the DEI space. You know, some of the things that Sharice was talking about, we've started to do. We have an anti-racism curriculum where everyone is very vulnerable, small group discussions that are very rich, and really get some of the details and nitty gritty, like conversations out in the open about like what it takes to not be biased overtly, and to check your implicit biases as well. We started that, and we started with the residents, and it was really, really well received. We now have, you know, the conversations in our M&M that are related to health equity when it comes to race, gender, socioeconomic status, and even language spoken. And I think for me, the things that I'm really passionate about are pipeline programs, because if we're really going to get a diverse surgical workforce, we have to start before people are, you know, residents. You know, we have to go back from medical school, high school, you know, even earlier if we can. And so I've seen some really robust pipeline programs that have been, you know, very remarkable, and hopefully something that we can recreate in my institution.
I think Dr. Burton has a question. Unless Dr. And if not, Dr. Ibukin.
Hi, this is Dr. Burton speaking. Hi, I'm currently a fourth-year resident at Carolinas Medical Center, actually in the application process right now for trauma critical care. Very excited about that. But one of the questions I had was essentially regarding that is, with this application process, just what kind of red flags, or actually what kind of positive signs are there to look for in a program regarding their commitment to diversity and inclusion, and, you know, not necessarily putting on a front per se as you're in the application process, but really determining that they're really committed and they do have goals in mind, and they would be willing to work with you with your ideas that you might bring to their institution as well?
I think that's an excellent question. I think that in speaking directly with residents, speaking directly with faculty will give you a sense of an institution's commitment to advancing DEI, and looking at attrition at the level of residency and at the level of faculty members, as well as whether or not you are seeing diverse representation in the leadership of the institution. Will also give you a sense of you know, the institution's commitment to diversifying their workforce, and whether or not you'll be supported in that institution or in that program. So you know, it's sort of separating out performative allyship from like real true allyship, and having an institution be very ready for supporting diversity. It's really in the makeup of the institution, I think.
And Dr. Ibukin.
Um, Hello, okay, it's evening on my side, so good day. I have quite a number of questions. I have asked some of them in the chat box. However, I would really like to ask in particular, so how do you avoid the tendency to overcompensate? Because it seems like when I'll give an example, and I hope that it can translate. In my institution, we have like 30 girls to about 100 plus guys. Now it seems like we have to do more to be taken as seriously as the guys. So putting that same situation in our discussion, there's this tendency to want to do more than want to take on more sacrifices, and in the bid ignoring your family, ignoring other things that might be important to you. So how do you handle that?
I can handle this question, I think, because I feel so passionate about it. I think that we have a tendency, like you said, to want to do more. I also think that people look at us and will actively seek us out. So we also have that added, responsibility. So for instance, people see that I'm a mother, and if they are mothers themselves, they may come and ask me to mentor them. Or if they are Black or African American, they may come and ask me to mentor them. So it ends up being that I want to do more, but then also more is asked of me. And I do think that I feel very passionate about this work. And I do find myself constantly like having the struggle of a work-life balance. And it is incredibly difficult to navigate sometimes. I mentioned on my first slide, like all the things that make me me. And 2 of the 5 things that I had listed there had to do with me being a mother and me being like a devoted family member and friend. And so I do think that is something that we have to be cognizant of, but know that you don't have to go above and beyond. We need to change the culture. You need to do you and be okay with being excellent and not feel like you have to be better than someone else to prove your worth. And I do think that everyone's work-life balance is going to be slightly different, but in order for you to feel satisfied at work, you're going to have to make sure that you are achieving that balance. And the way that you do so is by having the support of your department. And I think that's where like having conversations with your, the chief of your division, the chair of your department, or even your other colleagues that might be able to help out if you need to take your kid to the doctor, which happens sometimes. Like that's where you have to achieve that. But you're right, it's a lot that is that we put on ourselves. There's a lot that is asked of us as well. And we have to do a good job of making sure that we have these checks and balances where we're not overextending ourselves so that we can be excellent.
One of the other questions that Dr. Abukin put in the chat, it strikes home this week with the death of Madeleine Albright and her comment about there being a special place in hell for women who do not help other women. And I think that is that can be expanded to anybody who has been historically marginalized and underrepresented. It is not about there are a finite number of spots and a competition for a finite number of spots. It is truly helping all of us to help each other and ultimately to help our patients.
I was just gonna echo with what Randy said. So you're sort of touching on this minority tax issue where you being, the one underrepresented minority person or marginalized person in your department or institution. And so you get asked to do a lot of the DEI work that sometimes is uncompensated or sometimes not, you can't really apply it towards promotion, and you find yourself on many committees You're not having the time to apply for grants or do your own research. And so how do you sort of navigate that? And I think, it's tough, right? Because you're passionate. Some, most of us are very passionate about that and you want to do the work. But you want to be able to, it's a balance, but it's also an integration of not being so committed that you don't have time for anything else, including your family. And so you have to really learn to say no. And really, I hope that we get to the point where DEI work is everyone's work to do, and not just the underrepresented minority person in the department doing it all. That, and I think Lillian actually put this in her talk, and I think the COT has done a really good job of making sure, starting that process of saying, it's everybody's work. What are you doing for DEI in every aspect of the organization? And being able to answer that question so that it's not always falling on one person.
I think Dr. Bulger put something in the chat, and I think that we're actually looking at that from one of the organizations that I'm a part of, from a membership committee standpoint as well, from a contribution. It aligns with the resource aspect. If people are being promoted for getting grants and publishing and not being promoted for important work in DEI and health equity or advocacy or other very important work that is done. We all do things for 3 reasons, really. One, it's the rules, and you are or are not a rule follower. I mean, you have to do certain things to keep your license and to keep your privileges. We're passionate about it, or we're incentivized to do it. And promotion is a big incentive in the academic world. And the metrics are different. And I am starting to see more and more that promotion committees across the country are doing this, but it is by no means universal.
I don't know if everyone can see everything in the chat, but I think people have been commenting on some programs or initiatives that their institutions have undertaken, including DEI awards and recognizing excellence in that area, putting DEI into the promotions process. I mentioned that we developed something at our institution involving facilitated peer mentoring groups where you have one senior mentor and a group of junior mentees, because we don't have enough senior mentors, and whether it's, I think that's just a generality, not even including the fact that we don't have enough URM senior faculty. And we're trying to recreate something like that in our mentoring subcommittee in the AAST. So I just wanted to point out, if people aren't following the chat, that there's lots of great things that people are mentioning.
That is the group mentoring is one way to address some of the attrition aspects and the leaky pipeline. There are also regional mentoring that can take it, that can do sort of cross-institutional mentoring, in addition to within institutional mentoring is another way to address that mentorship aspect. I don't know if any of the other panelists have other ideas or things that they have seen work from a mentorship aspect to help address the attrition rate as well as the pipeline aspect.
At my institution, we also have a URIM mentorship pairing that happens. But again, if you have few numbers, trying to mentor few numbers. I think we need to start with diversifying our surgical workforce so that we have more people to act as mentors. And then of course, we have a lot of people who are junior and at the lower end of the academic hierarchy. And as you start to ascend, it gets fewer and fewer. We just had our very first Black woman become a professor at Emory in the Department of Surgery. And that was this last, academic year. So there are not a lot of people to mentor, and that's for women, just gender, race as well. So I do think that we have to start with getting more people in the door.
We've also I've been looking into trying to find existing programs on cross-cultural mentoring or even culturally aware mentoring. And I mean, I think we don't do a very good job in general of measuring how effective any mentor-mentee relationship is, and that we could probably all learn to be more effective mentors. But I think that while we're waiting for the pipeline to, improve, that there's still a lot of people that need to be mentored. So trying to sort of train up the mentoring workforce.
No, Lillian, that's terrific. And I think that would be a great topic for maybe one of our webinars. Learn at it, because I know Karen can probably relate to this as well, but when we came up, there were far fewer women, and every single women resident, they were assigned to you, and you can only mentor so many people, right? So I think that there needs to be a strategy in place to train people who really want to be good mentors, to make sure that they're conscious of the cultural issues, but can serve as mentors to the next generation, of very diverse candidates. I think that we need to do that. We need to be responsible for that. I think as leaders, that's critical. So that's a great program. I'd love to hear more about that.
There's a question about how we practical advice for people to be vocal allies and vocal mentors. And I do think training helps. And I honestly think for as much as many surgeons do not like to role play, I think role playing and giving people the words and giving people a script so that the first time they dip their toe in that water, they have practiced what they're going to say. I'm sorry that made me uncomfortable. I'm sorry that, or not I'm sorry, because you shouldn't apologize here. But giving a script, I think is helpful. And then amplifying that. I saw there was somebody who had vocally stood up for a co-resident, and that was amplified on Twitter. And so to make people aware of how important that that allyship is.
I think that's very, very important. I was just going to say, I think it goes to, the institution's readiness for diversity in preparing the faculty for how to be a mentor, how to evaluate our trainees. I mean, I think we really need to begin shining a really bright light on this issue of attrition and retention of our trainees and figuring out strategies to eliminate that.
There are a lot of resources on this topic. If you search like bystander, upstander trainings, you might be able to get resources, but it really does give you the language that Dr. Brazel was talking about, so that when you are standing up, you know how to tell someone that you're uncomfortable in a way that is not offensive or doesn't invoke anger or any other type of negative emotion. So I would just suggest looking up bystander, upstander trainings. We do it for our faculty, our staff, our residents mainly, but it's something that can be a nice tool in your toolbox.
And I think there's a comment in the chat from Dr. Knight about even just opening the door, and people are very afraid of getting it wrong. to be told that just by showing up and standing with, even if the first time they do it, they don't have the voice, but just by showing up and standing with, that's an incredible first step. And they will likely find their voice if they're willing to take the first step. We are 3 minutes from the top of the hour. Does anybody have a last question, or any of the panelists have a last comment?
I would just like to say, although we certainly have a really long way to go, I find it very encouraging that there's now increasing numbers, and that, you know, there's power in the masses, and that I think we are stronger together. So I hope that there is some positive takeaway from this session about having such energetic, great people. Especially I look at all the work that you guys are all doing who are on this panel, and it's just amazing. So thank you for letting me be part of this panel.
All right, I would like to thank all of the panelists, and I will end with a plug for the next few years as the program committee chair for the AAST. I have a little bit of leeway with the program, and so proposals for allyship training, panels about sharing and being vulnerable will be looked on extremely favorably. So I look forward to hearing from a lot of you while I have a chance to use that voice for this organization. And I will close by thanking Dr. Bulger and Dr. Davis for the opportunity to have this panel and have this discussion. And probably most importantly to Afia Jones, who coordinated everything, coordinates this, kept us all in line. Huge thank you, Afia. I look forward to seeing all of you and many others on our next webinar.
Thank you so much, everyone.
Yes, thank you. This was great.
Thanks, everybody.